Okay, so so far we've covered all the topics there with the red outlines, and today we're going to talk about what do I do after 5 years of an oral bisphosphonate, which equates to 3 years of an intravenous bisphosphonate, so like zoledronate. And we're also going to just cover what I do after 10 years of a bisphosphonate. So I have a case here. It's probably on Mentimeter as well. I hope I sent it through to Kareem during the previous presentations. So this is a 74-year-old woman referred to your endocrine clinic. She's been on alendronate for 5 years following diagnosis of lumbar osteoporosis, and she was above the FRAX threshold, so she was put on the alendronate. No other secondary causes have been identified. She's not on steroids. She has no history of any fragility fracture. Currently, her FRAX is below the treatment threshold. So this is after 5 years of an oral bisphosphonate. And you did a DEXA scan, and that showed the numbers there below. So good improvements, lumbar T-score minus 1.2, and total mean hip T-score minus 2.5. So both have improved. She's 74. She's been on a bisphosphonate for 5 years now. No steroids, no fragility fractures. So what are you going to do? I don't know if Kareem.
Oh, listen, I didn't have that slide, I'm afraid. That.
Okay, well, as a backup, you've got the answer. Well, you've got the options there: A, B, C, D, E. Okay, so do you stop the alendronate and switch to annual IV-Zol? Do you continue alendronate and add annual IV-Zol, or do you stop the alendronate, reassess in 2 years? So that's your bisphosphonate holiday. Or do you stop the alendronate and reassess in 5 years? Or do you continue the alendronate for a further 5 years? Maybe some of you will write in the chat what you think. Let's see if I can open the chat.
So we've got lots of people voting for C.
C wins. By
Yes.
Okay, so C wins. So what I would probably do is actually option E, which is to continue the alendronate for a further 5 years. And so I'll just very briefly tell you the evidence base behind that decision. So there are two important studies in terms of oral bisphosphonates, which probably can be applied as well to the intravenous bisphosphonates, and that's the FIT and the FLEX studies. Sound like some sort of aerobics for studies, but they're actually just looking at the effects of alendronate over this course here, so over the course of 4 years in the FIT study, and you can see femoral neck bone mineral density obviously increases, and so does the lumbar spine bone mineral density. Okay, so this is everyone on alendronate for 4 years. Okay, and then the FLEX study is the continuation. Okay, whereby now half of them continue on alendronate. That's the solid black dots up here for femoral neck and down here for flex. So you can see continued improvements in the spine, and the femoral neck stays about stable. And then the other half switch to placebo. Okay, so you can see here a slight drop in the first few years in the femoral neck. This is off alendronate, having already had 4 years. And in the lumbar spine, curiously, there's even a slight further increase in bone mineral density, even off treatment. Okay, so the point here is in the first few years after stopping alendronate, there may be minor losses in the hip. So that's this graph here, very minor losses, but still remains above the baseline when you started them on the treatment. And there are no substantial losses. And if anything, there may be even further gains at the spine. And that's this graph here. So don't worry too much about stopping treatment when appropriate. However, in this case, why is it not the most appropriate thing to do? Well, that's based on this. Okay, so this was a study in JAMA in 2014 that basically analyzed the 100 or so patients in the FLEX study to see who had fractures in the FLEX study. Okay, there were larger numbers in total, but the numbers of fractures were about 100, and tried to stratify what were the risk factors for the ones who had fractures. Okay, and so the only two things that they found were significantly predictive of fractures when off a bisphosphonate, so during the holiday, was your hip T-score. So hip T-scores of less than 2.5 or total hips less than minus 2.3. So this is these big bars here, the dark blue, okay, and also age. Okay, so essentially the lower your hip T-score, if it was lower than minus 2.5, it was predictive of fracture when you're off treatment. So on stopping fracture, the risk is greatest if your hip T-score is less than 2.5. So based on this, in the UK, we have the National Osteoporosis Guidelines Group. They've put together this set of guidelines, which is what to do after 5 years of treatment. And they suggest continuing treatment in high-risk patients, which they define as those greater than 75 years old, those who have had a previous hip or vertebral fracture or who have fractured during treatment, obviously excluding any other cause, such as not taking their medication or any other secondary cause. If they're on 7.5 milligrams of pred or equivalent or above, this guideline is written predominantly by rheumatologists, so you may argue that actually, more than 4 milligrams would probably be a more endocrine and modern approach to this point here. And hip bone mineral density T-score of less than minus 2.5 and above the NOGG interventional threshold as according to FRAX. So these are the main parameters where we tend to continue for another 5 years after the first 5-year course. Okay, so in this case, the patient had a hip T-score that was that met this criteria, and therefore should continue because they're at very high risk of further, predominantly actually vertebral fractures, according to that study, in the Bauer study, if they stop their bisphosphonate. Now, what they do in the US, well, they have slightly different angle. So here you can see they don't look at age. They do consider any previous hip or vertebral fractures an indication to continue. They don't talk about steroids. And here they include hip or spine less than minus 2.5. And they also set the intervention thresholds at 20 or for major osteoporotic and 3% for hip fracture, which is slightly different to the thresholds that you may have seen on FRAX when you ask for guidance, which are age dependent. In America, they're not age dependent. Okay, so these are the NOGG 2017 and the Endocrine Society 2019 guidelines and what to do at the 5-year point. The same applies for 3 years of zoledronate, whether you're going to go to your 6 years of zoledronate or not. Okay, so bisphosphonate holiday is not a retirement. I don't think anyone's going to be going on a beach like this anytime soon at this rate. But anyway, so how long is the holiday? So this really depends on the potency and the affinity of each bisphosphonate. So for alendronate, I typically keep them off it for 2 years and then reassess. Risedronate has comes out of the bone and has you start to see bone turnover marker change coming back to normal earlier than alendronate. A bit short. And for zoledronate, typically 3 years bisphosphonate holiday. And the point of this bisphosphonate holiday, as you probably all know, is to allow this microarchitectural remodeling, thereby rapidly reducing the cumulative risks of these atypical femoral fractures and osteonecrosis of the jaw that everyone, well, all patients are so worried about, and the Daily Mail is so worried about in these very safe, generally, and very highly effective drugs. Okay, so the important thing is when you take a patient off a bisphosphonate, you need to tell them that their bones are still protected. This is because of that long-lasting action of bisphosphonates, unlike denosumab, which I will talk about in a future session. So tell your patients, I'm stopping your bisphosphonate holiday. This is to allow microarchitectural remodeling, to repair any micro defects. Your bones are still protected during this time, but we just let the bones wake up slightly to repair the micro defects. This will minimize your risk of these very rare teeth problems, and a rare type of hip problem is essentially what I tell patients. Okay, so what do I do after 10 years of an oral bisphosphonate? So after 10 years of alendronate or after 6 years of IV alendronate, well, at this point, you definitely need to stop because they've had a very prolonged now suppression of bone turnover. And so you should stop at this point. And there's no real data to suggest extending courses beyond this point is of any benefit at all. Okay?
So that's a retirement.
So it is, yeah, exactly, perfect. Yeah, we're on to retirement now at 10 years. But no, you will stop after 3 years, and you may reassess after 3 years of that retirement. You will then have to think again. So it's still a bit of a holiday in actual fact, because they can have another 10 years 3 years later. Okay.
What, you retire and come back to work?
Exactly. Yeah. So retire and come back to work, and the first one was a holiday. Okay. So those are the 2 points I wanted to tell you about today, and I hope you found that useful.
Thank you, Alex. So should we always be doing a DEXA before we stop them?
Yes.
At 5 years?
Yes, that would be the typical pattern of play. That you do the 5-year DEXA. Basically, under the UK guidelines, you're seeing if the hip or the hip's T-score is less than -2.5, as that would be a criteria for continuing.
So all of those 5 criteria, do they have to meet all of those 5 criteria in order for you to continue for another few years?
No, they only need to meet one of those criteria because that will push them into the high risk group. There's sometimes, there's a bit of flexibility, I think, in some of them, in some of the patients, because at age of 75, covers quite a few patients. So you really need to start thinking about other aspects of it. And also steroids themselves are a risk factor for osteonecrosis of the jaw and atypical femoral fractures. So sometimes there's a slight individualized approach to each patient where you may take into account the bone turnover markers, how suppressed they have been over the course of time. But this is the general sort of guidelines.
Perfect. There's a question on the chat, Alex. Is it actual T-score, or can we consider a specific percentage improvement as well?
Well, so the Bauer study basically didn't find any association between change in DEXA scan and their risk of fracture. The only associations they found was in the stopping the drug T-score. So the actual amount that they've improved does not predict their subsequent fracture risk.
Okay, that's really helpful. Okay, great. Thank you, everyone. So if there's no more questions, hopefully you can all see the QR code if you want to scan that. And I will bring this session to a close.